right, I see Maria back. Hello, everyone. This is Mary Funseth. I'm from Superior Health Quality Alliance and also Metastar in Wisconsin. I'm a social worker and quality improvement advisor for Superior Health. And today it's my pleasure to be your facilitator for week 3 already. Today's presentation, again, for the week 3 of chronic kidney disease structured collaborative for management of early stage CKD. We are honored today to have Dr. Jonathan Siegel be our presenter. And we are going to start off today with some welcomes and a quick round robin share. And if we can, I will call your name, and if you could then share with us your name, title, clinic or organization, the location, if you're Michigan or Wisconsin, Minnesota, and so on. And then once we hear that, then we will go into looking at the quick action plan back to our participants on today. So first we'll start with introductions, and we're going to start right off with our presenter, Dr. Siegel.
Great, it's a pleasure to be here today. Thanks for the opportunity. So my name's John Siegel. I'm a nephrologist at the University of Michigan. I've been in practice for a little over 20 years, and most of my clinical work is involved with patients with advanced chronic kidney disease and those who are on dialysis, and particularly home dialysis. And I do some of my academic work involves measuring and reporting on the quality of outpatient dialysis facilities. So pleasure to be here and looking forward to talking about some of the management strategies.
Thanks for being here. We're looking forward to hearing about these things. Maria, you're up next.
Okay. I'm Maria Rainier. I work with the Stanford Health in the upper Midwest. We have dialysis and nephrology in Minnesota, North Dakota, South Dakota. We also have some dialysis in Iowa. So, and I'm the senior director for the enterprise for those services.
Thanks, Maria. Next, we'll go to Jerry Henniker.
And I am Jerry Henniker. I am also with Superior Health Quality Alliance. I'm a registered nurse, and I work as a program manager for Stratus Health, which is a partner with Superior Health Quality Alliance.
Thank you. We'll go on to Deb.
Good afternoon from Laverne, Minnesota. I'm Deb Winia, like you said. I'm an RN, and I do employee health, work in surgery, and I also have a personal interest. My dad just passed away from chronic kidney failure. He was on both home dialysis and the hemodialysis for about 1.5 years. I work for Stanford Laverne.
Thanks, Deb, and I'm so sorry to hear about your dad. Dr. Campbell.
Good afternoon, everyone. I'm Orville Campbell. I'm a nephrologist by training. I practice between the years of 1995 to 2019. I am currently the Vice President for New Business Development and Strategy at MPRO, but I reside in Music City, USA, Nashville.
Thank you very much. And Diane Carlson.
Good afternoon, everyone. My name is Diane Carlson. I work for Midwest Kidney Network. I'm executive director. We cover a 5-state region, Michigan, Wisconsin, Minnesota, North and South Dakota, covering and serving 52,000 people who have kidney disease there. It's been a lifelong profound interest in helping to try to slow the progression and identify early. So this is very exciting work. Thanks for everybody on the call.
Thank you, Diane. Janelle.
Yes, hi, my name is Janelle Gagne. I'm a registered dietitian. I reside in Rochester, Minnesota. I've been working in the area of nephrology for 33 years, and I've worked with patients with CKD, all the home modalities, as well as in-center dialysis and transplant.
Thank you, Janelle. All right. I think I went round robin with everyone. Jerry, I think let me know if I did not. And at this moment in time, Deb and Maria, not putting either of you on the spot, may feel like that, but we're not. So if you want to pass at this next question, feel free. And we're just talking a little bit about the action plan. I know, Maria, you were unable to come last week, and Deb, you weren't able to quite come through the whole event. But just checking with you, did either of you happen to consider the action plan from last week, which is to pick 5 random patients with diabetes and no formal diagnosis of chronic disease and calculate their eGFR using the eGFR calculator?
I apologize, I did not do this.
It's no problem. Again, don't want to put you on the spot, but we're going through this at this point. Deb, did you want to pass?
Yes, I did not do it either,
Okay.
sorry.
That's fine. Please consider it. This is something to think about as you review last week's presentation, and then come back to us if you have some questions and perhaps some feedback about it. All right. So, So today's objectives are going to be to describe which medications can slow the progression of kidney disease, explain what medications should be avoided in CKD, and understand the impact of lifestyle modification and comorbidity management for those with CKD. We also have a polling question today, and this is a true or false, as you can see. So Jenna, would you like to pull up the polling question, please? Oops, sorry. Let's see, Jenna, will that pop up the results? It does. So we have a 50-50. So now let's talk to Dr. Siegel. Tell us a little bit about what this question should be.
Sure. So we're going to get into a little bit more discussion about the role of ACE inhibitors and angiotensin receptor blockers in the management of chronic kidney disease. But one of the things that I see in clinical practice is people who get fairly gun shy about using these medications in people with reduced kidney function. And so it's really, from my standpoint, the answer is false. And that these medications have been clearly shown to decrease the progression of chronic kidney disease, particularly for people who have proteinuric kidney disease, where they're spilling protein in the urine. So I feel like this is one of those myths that is out there, and just wanted to bring that up as kind of a discussion topic, and we'll get more into it in just a few minutes.
Thank you very much. And with that, let's move on right into your presentation.
Great. So I came across this graphic, and it just kind of gives an idea of when we think about the trajectory of people that have chronic kidney disease. This shows 2 different paths, and really there's a third path that isn't shown here. But I think the starting point is, if we had a completely hands-off approach and didn't do anything to someone that has chronic kidney disease, many people would experience a slow and steady loss of kidney function over time. So that's kind of what's shown as the baseline rate there of kidney loss. And then, if we're not careful from a safety standpoint, there are adverse events that people can come across that actually worsen their kidney function. And so whether that's IV contrast for heart catheterization, or treatment with aminoglycosides, or a potential overuse of diuretics or things like that, those can all contribute to a decline in kidney function, or hasten the decline in kidney function that can potentially lead to end-stage kidney disease. There's a third line on here that's not shown that would be sort of above the baseline rate. And so you can think there are some positive interventions that we can do as well that might slow down the rate of kidney loss over time. And so that might be things like using ACE inhibitors or angiotensin receptor blockers or SGLT2 inhibitors, which we're going to talk about. It might be excellent control of their blood pressure and other interventions that we can do that might actually delay progression. And so that's really the whole point of this, is that based on how careful we are and how thoughtful we are in somebody's management, we can potentially steer that ship in one direction or another and hopefully avoid the development of kidney failure. So if we go to the next slide, let's start with control of hypertension, since I think this is really the cornerstone of management in someone with chronic kidney disease. And what I'm always amazed with is that it's taken a long time to try and figure out where exactly the blood pressure should be in someone who has chronic kidney disease. There have been numerous guidelines that have come out with recommendations, and they don't all agree with each other. And so while everybody agrees that a blood pressure target of less than 140 or over 90 is appropriate with someone with kidney disease, there's been some controversy over whether lower blood pressure targets would be helpful. And so specifically a target of less than 130 over 80, and what exactly are the benefits of reaching that target and who in particular benefits from it. And so to sum up a lot of debate and discussion, in patients that have chronic kidney disease who are spilling protein in the urine, they probably stand to benefit the most with a lower blood pressure target. And that's depicted in the graphic on the right-hand side, whereas we see increasing amounts of protein excretion as we move from left to right, then there is a larger decline or larger improvement in the decline in kidney function with a lower blood pressure target. So when people have very modest amounts of protein in the urine, the blood pressure target doesn't seem to have as big of an impact as it does in those who are spilling more protein. So that's one, I think, take-home message, is that when patients are spilling protein in the urine, getting the blood pressure down much lower is really important. And then when we looked at outcomes, the big key things that we've looked at are progression to needing dialysis or end-stage kidney disease, and then overall patient mortality. And again, when we've looked at more aggressive targets like 125 over something that's less than 80, those with proteinuria seem to have benefit from both progression and a mortality standpoint. In those without protein in their urine, the more aggressive blood pressure target doesn't seem to have as big an impact in terms of slowing their progression towards end-stage kidney disease. So that's kind of the nutshell. I think obviously control of blood pressure is important, and how we measure blood pressure is also important because we're making treatment decisions based on those readings. So for an in-office blood pressure measurement, we've really moved towards an automated blood pressure monitor. And so the patient is in the exam room, resting quietly for 5 minutes. You hook up the blood pressure monitor, and essentially it has a timer. So the staff leave, the patients by themselves, and taking 3 readings with a minute or 2 pause in between each reading, and then either looking at the lowest or the average of those readings. That's really become, I think, the gold standard for in-office blood pressure measurement. I'll also put a plug in for home blood pressure measurement, since that can also be critically important, since so many people have a component of white coat hypertension, or we just don't do a great job measuring in-office blood pressures. People are stressed to try and get to the clinic. They have trouble parking. They get in, we put them back in an exam room right away. We don't wait. And then we check their blood pressure, and no surprise, it's elevated. So a couple things to think about in terms of both technique for measuring blood pressure as well as the targets that we aim for. So let's go to the next slide. So let's get into the discussion about ACE inhibitor use and angiotensin receptor blocker use. For decades, this has been our go-to and mainstay of treatment in those that have chronic kidney disease. And particularly, again, those with chronic kidney disease that spill protein out into the urine, it's that group of people that has the biggest benefit in terms of being on an ACE inhibitor or angiotensin receptor blocker. Interestingly, for those that have chronic kidney disease where they don't have any protein in the urine, while ACEs and ARBs are still a great choice for controlling blood pressure, it doesn't seem to convey the incremental benefit that is experienced by those with proteinuric chronic kidney disease. So not a bad choice to use in people without protein in their urine, but not the same disease slowing attributes that we see in those with proteinuric kidney disease. And then when we get into some of the details, when we start an ACE inhibitor or an ARB, we anticipate to see a small increase in the creatinine and a subsequent reduction in the glomerular filtration rate, or GFR. And that sometimes makes people fairly anxious because medicines are supposed to help your kidney function. And so when we see the creatinine go up right after starting, sometimes people get a little gun shy and will want to stop the medication. But the way I look at it is it's expected because of the hemodynamic changes that we see in the filtering units in the kidney. And two, if those medications slow down disease progression, then you might have a small short-term loss for a long-term gain in terms of changing the slope or the rate that kidney disease progresses. Now, clearly, if the creatinine goes up by more than 30%, that would be a good reason to pause. Sometimes we run into issues with potassium, so that can sometimes be a rate-limiting issue. That non-productive or nuisance cough can be seen in about 15 to 20% of patients, and that sometimes can be a barrier, at least with ACE inhibitors. Angiotensin receptor blockers tend not to have that issue. Angioedema is very, very rare. And then obviously these medications should not be used in pregnancy. But aside from those few caveats, these medications are the mainstay of treatment. And there really isn't, even in advanced kidney disease, stage 4 kidney disease with a GFR less than 30, there's still value in having these medications on board to slow disease progression. So let's go to the next slide. And so in nephrology, we have been relying on ACE inhibitors and angiotensin receptor blockers for decades, and there hasn't been much new in terms of a medication that could really slow down disease progression until this group of what are called SGLT2 inhibitors, sodium glucose transport inhibitors. And so this class of medications is really exciting because we now have a second major tool in our toolbox to try and slow down the progression to kidney failure, change the slope or decline in GFR, and even reduce mortality in this patient population. And so there are a number of drugs that are out on the market. These were initially studied in those that have diabetic kidney disease. And so you can see there are a few more choices there because those were the original studies. But even in those patients that have non-diabetic kidney disease, there is still benefit in using these medications. There are a couple limitations. They're not designed for advanced chronic kidney disease, so the GFR should be above 30 to start them. And because these medications cause glucose or sugar to be spilled in the urine, that can increase the risk of infections. And for reasons that are not entirely clear, there has been some association with some of these drugs and increased risk of lower limb amputation. So in someone with bad peripheral vascular disease or foot ulcers or things like that, these may not be a good choice in that patient group. But for many people, this can be a real game changer. And I see the question about how about stage 1 and 2, so early CKD, and the answer is yes, is that these were tested. The original studies were done in patients with a wide variety of kidney function, including stage 2 CKD. So really for anybody with stage 2 or 3, which is really where the vast majority of people end up being, that these medications can be of benefit. So yeah, great question, thanks. Let's go on to the next slide, unless I'm happy to pause here and see if there are questions about either ACE or ARBs or the SGLT2 inhibitors. All right, so we'll go on and talk a little bit about statins, so the cholesterol-lowering medications in chronic kidney disease. And you know, for many, many years, the paradigm had been measure somebody's cholesterol panel, and if their cholesterol was high or their LDL was high, then we would use statins to help lower the cholesterol and reduce their cardiovascular risk profile. And it became clear that in those with chronic kidney disease, that the increased risk of cardiovascular events was large enough that, and that statins were so powerful in reducing that risk that one of the major guideline organizations basically came out and said, you know, for anybody that's got chronic kidney disease with a GFR of less than 60, and if they're over the age of 50, that there's benefit for being on a statin medication. So a pretty simple kind of rubric to follow. The other way of looking at it is if somebody's 10-year risk of a cardiovascular event is above somewhere in the 7 to 10% range, they would also have benefit. And that's because statin use has a 20 to 25% reduction in both cardiovascular events, cardiovascular mortality, all-cause mortality. So notice that I haven't mentioned anything about the lipid panel. And so this is really the benefit of statins is regardless of where their cholesterol panel is. And so if somebody has a pretty good lipid profile, you could make the argument to use low or moderate dose statins if they've already had cardiovascular events or they have an unfavorable lipid profile, then using a higher dose statin may be appropriate. But even for someone with a pretty normal looking cholesterol panel, still has something to be gained by using these medications. And there was, just to kind of circle back, because there was a question again about the SGLT2 inhibitors in terms of the amount of how much delay on average there is. And I think some of that is going to be a bit dependent, but it's definitely, I don't know off the top of my head, but it's going to be I think months to years is potentially in the right ballpark. So it's a significant difference in those that aren't treated with those medications. So if we go to the next slide. So a brief word about metabolic acidosis. And so as we're getting routine chemistries on patients with chronic kidney disease, you may see that the serum bicarbonate becomes on the low end of normal or even below normal, dipping into the teens. This is highly dependent on the patient's diet. And so the more protein, in particular an animal protein that people consume, that really puts a higher metabolic load in terms of acidosis. And it appears that being aggressive with treating metabolic acidosis can also potentially slow down the decline in kidney function. Living with kind of a chronic metabolic acidosis and a low serum bicarbonate can lead to impaired mineral metabolism. So we see problems with bone health. Outside of the loss of GFR, we also see problems with protein energy malnutrition. So ideally, most of these studies have looked at trying to maintain the bicarbonate above 22 as a target. And so while we can prescribe sodium bicarbonate, You need a fair amount to help get the bicarbonate up. So it's typically, they come in 650 milligram tablets. You typically need a couple of those twice a day as a starting point. As an alternative, good old Arm & Hammer baking soda that you get at the grocery store, which is the same thing. It's sodium bicarbonate. You can typically start with a quarter to a half a teaspoon twice a day. And sometimes that's a little bit easier for patients because the bicarbonate tablets are quite large. You do need to be mindful that there's a sodium load that goes along with this. So we generally want to make sure that someone's got pretty reasonable fluid balance and control of their hypertension before starting them. But clearly, improving their bicarbonate can slow down the decline in GFR and potentially keep some people from reaching end-stage kidney disease. We'll go to the next slide. And then another controversial area has been in control of uric acid, and uric acid and kidney disease are kind of a two-way street. So we know that people that have low levels of kidney function often have higher levels of uric acid. There have been studies that have suggested that people that have high uric acid are at increased risk of faster progression of kidney disease. And there have been a number of studies that have looked at the impact on lowering uric acid and whether you can delay progression of kidney disease. And so this was a relatively recent study that was fairly comprehensive and unfortunately found that lowering of uric acid did not impact the rate of major cardiovascular events, did not unfortunately slow down the risk of kidney failure or all-cause mortality. There was a small improvement in blood pressure control. One of the things that is really important to understand about most of the studies that are in the literature is that they looked at people that had relatively modest elevations in their uric acid. And so it's not clear that in patients that have much more marked elevations in uric acid, say uric acids that are 10, 11, 12 in that range, whether lowering their uric acid may provide some benefit. So that question is still, I think, unanswered, but for more modest elevation, say a uric acid that's 7 or 8, and then getting it down into the normal range, there does not appear to be a benefit in slowing down disease progression. So more to follow on that one. And next slide.
Dr. Siegel, if it's okay,
Yeah.
we did have a question about the number needed to treat for interventions.
For SGLT2 inhibitors or something different?
Yeah, and my apologies. So Dr. Berg, I think you were the one who asked that question of me. And so do you want to clarify more, Dr. Berg? It's SGLT.
Oh, okay. Yeah, I apologize. I don't actually know off the top of my head what the number needed to treat is, but it's a fairly favorable number in terms of the whole proposition. And I think one of the issues that's come up with SGLT2 inhibitors is who's in the best position to be prescribing these medications. So there's a whole range. Clearly primary care doctors can do it. Some people have their endocrinologist are taking a lead role, and I think more and more we're seeing nephrologists take a lead role as well. So I think it's pretty fair game for anybody to at least start those prescriptions and then obviously monitor kidney function afterwards. So in terms of the other thing I want to just kind of put on the radar screen is sleep disordered breathing or obstructive sleep apnea. We see that this is much more common in the population that has chronic kidney disease compared to the general population. And that's a mix of both obstructive sleep apnea as well as some central sleep apnea. And nocturnal hypoxemia can lead to a host of problems, but in terms of today's discussion, it has been associated with an accelerated decline in kidney function. And so while it's not entirely clear that then treating sleep apnea and using CPAP or BiPAP or one of those therapies can then slow down progression of kidney disease, that certainly would be, there are lots of reasons, obviously, to treat sleep apnea when it is diagnosed, both from a quality of life standpoint as well as from cardiovascular complications and potentially kidney function as well. So I generally have a pretty low threshold to order sleep studies if people have symptoms that are suggestive, just because we do tend to find it quite a bit more in the population with chronic kidney disease. If we go to the next slide. Just a quick word about vaccinations and chronic kidney disease. So obviously influenza and pneumococcal are pretty straightforward. I just wanted to mention the value in doing hepatitis B vaccination for people with a little bit lower level of kidney function, because the response, the immunologic response is better if we vaccinate people for hepatitis B earlier. If those people go on to need dialysis, we obviously offer hepatitis B vaccination through the dialysis programs, but people tend to have a less robust immune response if we wait till they already have kidney failure, as opposed to doing it early in the course of their kidney disease. So think about hepatitis B vaccine and obviously COVID vaccination. People that have kidney disease, and particularly those that have kidney failure, seem to be at much higher risk for getting COVID, and when they do have COVID, tend to have worse outcomes. So that's critically important for everybody in the population, but particularly those with chronic kidney disease. And the next slide. A brief word about some medications to think about. So obviously we do a lot of counseling to try and avoid non-steroidal medications. To be perfectly honest with you, occasional use of non-steroidal and relatively modest doses is probably fine. The people that we see who really get into trouble are those that use high doses of non-steroidals on a regular basis, so daily for months to years, are the ones that really can get into trouble. So occasional use is okay, but we obviously would try and discourage that if possible. Herbal supplements are another one that comes up. There are some herbal supplements that are specifically marketed for kidney health. And the problem with many of these supplements is that they're not regulated by the FDA, and they can contain contaminants with heavy metals. So things like lead, mercury, and arsenic, those can clearly have a negative impact on kidney function. So we do try and avoid herbal supplements. Need to be mindful of phosphorus-containing bowel prep. So for someone who's having a colonoscopy, we want to avoid like things like Fleet's enemas that are typically phosphate-containing, and use preps more like Go Lightly or other bowel preps that don't have phosphorus. There's been a lot of discussion about proton pump inhibitors, which are widely used, and whether they have an adverse effect on kidney function. There were a couple large studies that were published that suggested that people who took proton pump inhibitors for a long period of time had higher risk of having chronic kidney disease than those that either didn't take it at all or took H2 blockers as an alternative. It's not clear the strength. Some later studies have questioned the strength of that association, but given that there's so many people that take proton pump inhibitors that may have only had a short-term indication and end up on them long-term, I do think there's some opportunities to try and see if you can switch to H2 blockers or even stop therapy altogether. And then opioids, particularly those at higher doses, are associated with increased risk in those with kidney disease. So we just need to be cautious about those. And then a reminder to think about dose adjusting some of our common medications. There are many antibiotics, things like gabapentin and oral anticoagulants, and oral hypoglycemics need dose adjustment in the setting of lower kidney function. So not to forget those. And next slide. And then a quick word about imaging. I think most people are fairly cautious about using iodinated contrast for CT studies. Clearly, that risk goes up if the GFR is less than 30. There's some other factors there, clearly taking things like non-steroidals at the same time. It's also important how the contrast is given. So intra-arterial contrast, like for a cardiac catheterization, appears to be at higher risk than venous contrast that we would use, for example, for a CT scan. So CTs need a bit of caution, but aren't, in the right circumstance, you can give IV contrast to some patients with chronic kidney disease and get away with it, but it needs a little bit of thought in terms of what the risk level is for the patient and what their level of kidney function is. MRI is, I think, a safer option. There used to be an enormous issue with gadolinium in patients that had kidney failure and something called nephrogenic systemic fibrosis. It turns out that that was probably limited to a couple specific types of contrast agent, and which are, I think, generally avoided by most radiology imaging groups. So MRI with contrast is probably the safer alternative for most people with chronic kidney disease. And if we go to the next slide, I'll just say a brief word about nutrition and lifestyle. I know we have a whole section coming up on nutrition, so it's hard for me to not put slides in about that, but weight loss can potentially help kidney function out, and smoking cessation has also been associated with less disease progression. And there was a question about bicarb and mucomist in terms of just going back to contrast prep. So there was a lot of excitement about mucomist several years ago in terms of trying to prevent contrast-induced nephropathy. After a lot of further review, it doesn't appear that it has much benefit. And so I think that's one of those things that was very popular for a while and more recently has fallen out of favor. So we're not giving mucomist to prevent contrast-induced nephropathy for CT scans. And the bicarbonate also, I think, is it falls into the category of I don't think it hurts, but it's not clear that there is across the board benefit. And so hydration is important. How you hydrate somebody is probably less important, but making sure that they're not in a volume depleted state before you give contrast is probably the key thing there. And if we go to the next slide. And I think this is our last one, which is just some guidelines about frequency of monitoring in terms of keeping track of blood pressure control, kidney function, a urine to look for protein and monitor that, some lipids since we have a low threshold to treat with statins, and then things like anemia and bone disease. So, and obviously, the level of kidney function, the lower the kidney function, the more frequently we'll want to follow along with some of these. So let me stop here and see if there's other specific questions, or otherwise we can open up for more general discussion.
I do have a question about the kidney disease risk equation that was discussed at ASN. I've just been doing a little bit of reading about it. I wasn't there. But how do you see utilizing that in conjunction with clinical interventions to reduce progression?
Yeah, I think that's a great question in terms of trying to, obviously we want to try and risk stratify people as best we can for a couple reasons. One, there's the realization that many people that have mild or even moderate chronic kidney disease are actually not going to progress and won't ever need dialysis. And so, so there are some people that we can have a little bit more conservative approach. And then there's going to be people who are at much higher risk of progression and may need to be referred to see a nephrologist sooner rather than later, may need more aggressive interventions in terms of blood pressure control or use of some of these medications to really try and slow down disease progression. So I do think that some of these risk equations can be helpful when you're seeing somebody early on and then trying to decide, how closely do I need to follow this person? Do I need to get this person to see a nephrologist for some additional help, or do they actually fall in a lower risk category where I can, where I can feel a bit more comfortable that they're likely to do okay?
Additional questions for Dr. Siegel? So maybe at this time, what we'll do is we'll bring up, we do have, and if you have some more questions, please feel free, put them in the chat or stop. Pardon me, apparently we have one more from the background. First, we have our algorithms, which I'll share again. And Dr. Siegel, if you could maybe speak a little bit to these.
Sure. So actually, do you want to start with this is looks like the emergency room one. I don't know if you want to start with.
Yes, I had those up in order. I apologize. 1 second. Let's see. First, we want to go with the assessment, correct?
Right.
There you go.
Okay, great. So, and this kind of recaps some of the things I think that were discussed in the first couple sessions. So, thinking about risk factors for chronic kidney disease at an office visit, and so a bunch of them that are listed out here. And then starting with obviously a creatinine and GFR estimate and a urinalysis to look for protein to then help kind of set the stage. The one thing that is, typically when we're talking about chronic kidney disease, we're talking about a time frame of at least over 3 months. And so if you're seeing somebody for an initial visit in clinic and you get initial labs, and if they have an elevated creatinine or you see protein in the urine, then you'd want to probably do some follow-up testing to get a sense of whether this is an isolated event, or see if there's old records to somehow establish the time course of their kidney issues, to understand, is it's really a long-term issue where I'm going to call them chronic kidney disease, or is it a more short-term issue or something that may need even more urgent attention? And so then for once we sort of get that part established in terms of the chronicity, and we have some idea of what stage their GFR is, then we can start to try and figure out what they need in the way of either referral or ongoing monitoring. One thing that I'll point out is that with the GFR calculation, I'm not sure if this has been discussed in the prior sessions, but it historically has been a race-based estimating equation, and it looks like we are probably on the cusp of that going away. And so you may see in the not too distant future that labs will no longer report out either Black or non-Black race with the GFR estimate, and many labs are going to be moving to a new estimating equation that doesn't look at that. So it'll just be a single value for everybody. So some people's GFR may be, they go to the lab at the end of December, they get one value, they have the same creatinine in January, but the lab switches estimating equations and their GFR calculation may come back a little bit different. And hopefully this is going to help reduce some of the health disparities in kidney disease. So just be aware that as you're thinking about GFR, your lab may change the equation in the coming year. And so with that sort of bit of a tangent, then once you're able to figure out what stage somebody is at, then you can go through and think about, do I need to change or do things different with medication use, think about treatment adherence, and then in terms of monitoring. And the comment in the chat about that these have been problematic for multiracial individuals, and I wholeheartedly agree with that. That lately, to be honest, even for pretty much everybody, I've just been kind of picking a GFR that's in the middle of the two, which is essentially what some of these new estimating equations are going to end up looking like. So hopefully we're moving in the right direction by refining our assessment of kidney function, but it's been a long time coming. And so one of the things that comes up for the emergency room is a frequent point of contact for many patients, for better or worse. And so it does seem like it's an opportunity to potentially get people plugged in for follow-up. So thinking about risk factors for CKD, and again, labs that get commonly done in the emergency department, and then trying to either get people plugged in to see a nephrologist for lower GFR, or to primary care providers for people that have a lesser decline in kidney function. And then again, at the bottom, just some things to be cautious about. And again, the IV contrast for CTs, I think, is still an issue, less so lately for MRI. And in fact, at our medical center, the radiologists have stopped checking creatinines before doing MRI studies. They're that confident that the contrast is safe for people at any level of kidney function. So that part is encouraging and certainly helps open up imaging options for people with decreased kidney function.
All right. I'm pulling us back. Thank you very much for going through those with us. Just for the sake of time, and then we'll go back to questions, if I may. I'd like to talk just a little bit about the action plan for this week. And if you are on the line with us at this moment and you completed something with last week's action plan, you can maybe type a little something in the chat and we'll notice that. But this week's action plan is to select 5 patients with CKD who have diabetes and hypertension and evaluate how many are on ACE and ARB or HARB and statin medication. Dr. Siegel, did you want to speak to this at all?
Sure. One of the reasons why I put this as an action plan is because if we look nationally, the number of people that have diabetes and hypertension, so people who would be prime candidates for being on an ACE or ARB, that number at the national level is, according to some studies, as low as 50%. So it seems like there's ample opportunity for improvement. And again, within our nephrology division at our health center, we use that as a quality improvement metric that we follow for our nephrologists is, of your proportion of patients with CKD, how many of them are an ACE or ARB. And so that's one of the metrics that we track for our providers. And we're in a little bit different situation since we're a bit more heavy-handed and maybe feel a bit more comfortable than some primary care providers. But even amongst my colleagues, we're more probably in the 75 or 80% ballpark. So even amongst kidney docs, there's still probably room for improvement.
All right, thank you. So at this point in time, we still have time for some questions or some discussion. Is there anything that we missed, Jerry, that we need to mention before we enter into a little bit of discussion before we close for the day?
I think we've got everything covered. Not to get too far ahead, but just a reminder, we won't be meeting next week. And so our next session 4, will be on December 1st, same time, same place. And we will be hearing about nutrition in CKD.
Thanks, Jerry. So let's open up your mics. Feel free to engage with each other, ask some questions of each other, and of course, of our speaker, Dr. Siegel, and Dr. Campbell from last week is on as well as the folks from Midwest Kidney Network. So this is our opportunity to open up the mic and talk through some things.
One of the things that we've been actually looking at and working on within this organization and trying to figure out what's the answer is really that earlier stage. You know, I agree with you, Dr. Siegel. We need to improve our nephrology area as well once they are referred. But a lot of times, because of access, most of these patients aren't being referred till 3B, which is, fairly late in the game. Not totally, but fairly. So how do we go about engaging our primary care providers across the nation to improve the kidney disease care? Because they're dealing with so many comorbid factors, not just kidney disease. But is there enough understanding of kidney disease that they're able to, early identify and appropriately treat?
Yeah, that's a great question and an absolute struggle across the board. I mean, you're not the only ones that are wrestling with this. And I think, for starters, there aren't enough nephrologists to see everybody that's got chronic kidney disease, right? So even access issues for people that have more advanced kidney disease is a problem in many parts of the country. And then if you start taking people that have stage 3A, there's just no way that we can see all those people. So one of the things that some health systems have turned to, with obviously with the huge uptake of electronic medical records, there are some opportunities to do one of a couple approaches. So one are these, best practice advisories. So, an alert that pops up that says, oh, your patient has chronic kidney disease based on a creatinine, and I see from their medication list they're not on an ACE or ARB. Should you consider it? So you can build in reminders for providers into electronic medical records that will do that. The problem is that there are so many potential reminders for all these aspects of care. Providers get fatigued, you just start making the things go away, and so they lose their effectiveness. So the other way of potentially trying to tackle it is with panel managers and doing this in batch settings. So again, with the capabilities of electronic medical records, you can look at, take a provider, all their patients in their panel, and then figure out, okay, based on testing, who meets criteria for having chronic kidney disease, looking at their medication list or looking at their blood pressure. We did an exercise in our division looking at people who were seen by nephrology who didn't have optimal blood pressure control, and then singled those people out and then had a number of simple interventions to try and either get them back in, do home blood pressure monitoring, do something to try and get better control of high blood pressure. So I think it's going to rely on those systems-based approaches to try and tackle, because the number of people we're talking about is relatively large, and you're absolutely right. In a given individual clinic visit with patient and provider, there's too many other pressing issues that they're trying to get through. And when the creatinine's 1.4, which is still reduced GFR, that's not screaming loud enough to get attention over the other competing things that are going on that day. And then obviously, the whole issue then comes down to is, okay, do we have the financial resources to support that kind of, those kinds of activities? Because now you're talking about having, some clinic staff or provider to go through and try and pull out these people and then come up with intervention. So it does take some time and effort, but I think that's going to be, ultimately, that's probably the most efficient way to try and tackle some of this. Because I like to think, and it's easy for me to say this, if you leave it up to the docs to do this, it will fail, right? I mean, that's, I think that's why the systems-based approach tends to be more effective.
Sure.
I think, Maria, too, one of the things that you can maybe consider is you could pull together some clinicians around some just lunchtime review, and we will have, as we mentioned, these things, the events each week recorded, as well as the slides. You'll have the slides, so you can also bring some folks together and perhaps have your own discussion panel around that, these topics. And, let us know if there's anything that we could do to help support or facilitate that.
And I just wanted to thank Dr. Siegel for plugging our Superior Health Quality Alliance, how to take a blood pressure and self-measure blood pressure program courses, which I'm not sure he knew he was plugging when he was talking all about blood pressure, but we do have those 2 courses on Superior Health Connect. I put the link in chat earlier and I'll put it in there again, but just again, another added tool to your toolbox for managing chronic kidney disease. So
It's been well received. We encourage you to use it. Anyone else have some thoughts about today's presentation, some questions, perhaps some thoughts that you had since last presentation, or any other needs that you have? Diane, it looks like you're maybe going to let us talk.
Well, I was just going to say, I thought this was really excellent, and the way that was presented was in such bites of understandable bites. Thank you. What an excellent hour.
Thanks very much.
All right. Dr. Campbell, any closing words from you today?
Yeah, I too agree that they were manageable, easy to understand bites. And I knew we were up against the hours, but I just wanted to make a plug for culturally competent healthcare, in that it is really important that we are cognizant of one of the things that's out there that's still not accurate, that ACE inhibitors aren't useful, or ARBs are not useful in individuals who are classified as either Black and or African American when they have proteinuria and diabetes. And we still fight that. I do some correctional healthcare work, and in the hospitals, in the academic setting, even in Nashville, we still fight that battle, that if there's albuminuria or frank proteinuria and the person is African American and or Black classified, they won't use ACE or ARBs, and that has to stop. Yeah. And that's all I have. Thank you for a wonderful talk, Dr. Siegel.
My pleasure. Thank you.
Yeah, thank you for everyone today for attending. And at this moment, we're going to conclude our presentation, our collaboration today. And we look forward to seeing you, as we mentioned, Wednesday, December 1st for nutrition and CKD. And we will be recording these and have them available for you soon. So thank you, everyone, and goodbye.